Welcome to meeting number 95 of the House of Commons Standing Committee on Health. Today's meeting is taking place in a hybrid format pursuant to the standing orders. Just a couple of comments for you, I guess, Dr. Humphreys, participating remotely. You have on your screen the ability to use interpretation. You'll see on the bottom of your screen a choice of either floor, English, or French. Please mute yourself when you're not speaking. Most of the time that will happen automatically, but if it doesn't, please tend to it and refrain from taking any photos of your screen or any screenshots. In accordance with the routine motion, I'm informing the committee that all remote participants have completed the required connection tests in advance of the meeting. Pursuant to Standing Order 108 Sub 2 and the motion adopted on November 8, 2023, the committee is resuming its study of the opioid epidemic and the toxic drug crisis in Canada. I would like to welcome our witnesses, Dr. Keith Humphreys, a professor of psychiatry participating by video conference and representing St. Michael's Unity Health Toronto, Dr. Dan Werb, the director, Center on Drug Policy Evaluation. Thank you both for being here today. We'll begin with your opening statements of 5 minutes, starting with you, Dr. Humphreys. Welcome to the committee. You have the floor.
Thank you, Chair. Thank you for the opportunity to speak to your distinguished committee today. My name is Keith Humphreys, and I am the Esther Ting Memorial Professor of Psychiatry at Stanford University School of Medicine and a former White House drug policy advisor to U.S. Presidents Bush and Obama. Today, I will briefly summarize some of the key conclusions of the Stanford Lancet Commission on the North American Opioid Crisis, which I chaired and which published its main conclusions in the Lancet Medical Journal last year. The commission comprised North American clinicians, scholars, and policymakers who carefully studied the opioid crisis in the U.S. and Canada and made recommendations for how to resolve it. In both of our countries, the opioid crisis originated in the healthcare system when insufficiently regulated pharmaceutical companies and healthcare providers increased per capita opioid prescribing by over 400% in a little over a decade. The fact that these drugs were legally made and of consistent known quality did not stop them from addicting millions and killing hundreds of thousands of people across North America. Some of those who suffered were patients. Others were individuals who gained access to medication prescribed for others that was given or sold to them through diversion. When prescription opioids are distributed in the community with little oversight, it is easy for each person who receives them not only to become addicted, but also to initiate addiction in others. To their credit, both the U.S. and Canada have subsequently taken significant steps to make opioid prescribing more judicious and safe. However, the expansion first of heroin and later of fentanyls in illicit drug markets has continued to cause great suffering, as you all well know. The Commission recommended the expansion of robust evidence-based prevention programs targeting individuals not yet using opioids, coupled with treatment and harm reduction strategies for those who are already addicted. Many of these strategies are in place in multiple locations across Canada, including methadone maintenance clinics, syringe exchange services, drug courts, residential rehabilitation programs, and initiatives that distribute the overdose rescue drug naloxone. The Commission saw no reason that harm reduction and treatment programs could not be offered side by side. Promoting public health should be a shared journey and not a competition. The Commission also endorsed the goal of recovery from addiction for all services, meaning that while it was clearly valuable and moral to save someone's life today, for example, from an opioid overdose, it is important to not yield to the soft bigotry of low expectations by assuming that surviving from day to day is all an addicted person can be helped to achieve. Tens of millions of people in North America have recovered from addiction, restoring their health and humanity while simultaneously benefiting their families and communities. Increasing the number of people who leave active addiction and enter recovery is a worthy goal to which all service providers and policymakers should aspire. This is the animating spirit of the recovery-oriented system of care currently being built in Alberta, a destigmatizing and optimistic vision which I believe should be spread nationally. The Commission recognized that safe supply programs, which distribute pharmaceutical opioids and other drugs in the community, are a subject of significant discussion in Canada. So I'll close by mentioning the commissioners were skeptical of such programs. The reason is simple. We have seen this movie before. If handing out prescription opioids with minimal supervision were good for community health, neither the U.S. nor Canada would ever have had an opioid epidemic. The first decade of the crisis should have taught us that the fact that a drug is legally produced and of known quality is no barrier to it causing addiction and death. Further, as the early years of the opioid crisis showed, it only takes a small amount of diversion to new users for an opioid distribution program to increase the prevalence of addiction. Even if we assume optimistically that 90% of people in a safe supply program take all provided drugs exactly as prescribed, and the other 10% divert only enough to each generate 1 or 2 new cases each of addiction each year, the number of addicted people doubles every 5 years. The Commission therefore recommended keeping faith with the prevention, treatment, and harm reduction strategies I have just described, which have evidence of making our shared addiction crisis better rather than worse. Thank you again for the opportunity to testify today, and I look forward to your questions.
Thank you very much, Dr. Humphreys. Next, we're going to hear from Dr. Dan Werb from St. Michael's Unity Health, Toronto. Welcome to the committee, Dr. Werb. You have the floor.
Thank you for the opportunity to present today. I am a social epidemiologist and the director of the Center on Drug Policy Evaluation at St. Michael's Hospital in Toronto. Canada's overdose epidemic is getting worse, and this has understandably led to a questioning of the current response and a reflection on what must change for Canada to overcome this all-of-society crisis. In that context, it's important to recognize where scientific consensus exists and where questions remain. So I want to focus my comments on 2 contested areas: opioid agonist treatment and supervised consumption services. So there's scientific consensus that opioid agonist treatments like methadone, buprenorphine, and others are the most effective approach we have for managing opioid use disorders and helping to stabilize people at risk of overdose. Over 3 decades, there have been multiple Cochrane systematic reviews and meta-analyses, which are the gold standard for evidence-based medicine, that have demonstrated that this class of treatments, which includes providing opioids such as methadone, buprenorphine, as well as diacetylmorphine and others, is effective at retaining people on treatment, reducing their use of non-medical opioids, and reducing their risk of overdose. Work that I led from a U.S. National Institute on Drug Abuse and Canadian Institutes of Health research-funded study across 4 countries also found that enrollment in opioid agonist treatment was associated with a reduced likelihood that people who injected drugs would assist others in initiating injection drug use, thereby potentially preventing people from becoming at risk of overdose. However, questions remain regarding opioid agonist treatment. For example, how do we best reduce the barriers facing people at risk of overdose who could benefit from treatment? How do we scale up treatment to those who need it? What types of medications are most effective given the extremely high potency of synthetic opioids like fentanyl, carfentanil, and nitazene class opioids? What kind of monitoring is required to ensure that patient needs are being met and medications are not diverted? Finally, how do we ensure that those who lose access to treatment don't end up reliant on the toxic drug supply and thereby at greater risk of overdose? These questions are important to investigate, but they do not change the fact that opioid agonist treatment is our best clinical tool for managing opioid dependence, and that recovery-based approaches have not demonstrated similar effectiveness. We should continue to focus our efforts on scaling up coverage to meet the needs of those who could benefit from this treatment, while also ensuring that we evolve the design of programs to respond to these important questions. Similarly, there is scientific consensus that supervised consumption services are effective at preventing people from dying of overdose. They are, in fact, the most effective structural intervention that we have. These services have generated evidence over 4 decades of operation and are now present in over 1/3 of all countries in the world. They have been shown to not only provide immediate life-saving responses to clients on site, but also can serve as pathways into the broader continuum of care for people who are at risk of overdose. This includes referring their clients to treatment, social services, and clinical care. However, questions have been raised about the limits of their impact. For example, some observers have questioned their cost effectiveness on the assumption that their impact is restricted only to the clients within the four walls of the sites themselves. On that, I would note that a study from my center, led by Indu Ramahan and currently in press at the Lancet Public Health, the world's leading peer-reviewed public health journal, recently found that the implementation of 9 supervised consumption sites in Toronto starting in 2017 led to a 67% reduction in overdose mortality in surrounding areas as far as 5 kilometers away, with significant positive rate reductions increasing year over year. This study adds to data from Vancouver as well as Sydney, Australia, which collectively demonstrate positive spillover effects of these sites across neighborhoods. If we're serious about ending the overdose epidemic, the chief question is, how do we best resource these services to fully integrate with the broader continuum of care, such as social services, including housing, clinical care, and substance use treatment, so that they are effective as possible in preventing overdose as well as in helping to connect individuals with services that they need? And how do we best design and manage these sites to minimize potential public safety concerns for surrounding communities? Rather than seek to reduce the number of the funding of these sites, we need to resource and design them to meet the needs of those at greatest risk of death, as well as the communities in which they are located. This is why I am so troubled that supervised consumption sites are slated for closure in both Sudbury and Timmins, Ontario, and are under threat elsewhere. Given that Northern Ontario's per capita overdose mortality rate is roughly 3 times the provincial average, we simply cannot afford to backslide, or more people will die. The overdose epidemic will soon claim more Canadian lives than COVID-19, and mostly young lives. Let us recognize our collective national grief and transform it into a comprehensive evidence-based roadmap to end overdose based on the evidence of what works and what must be adapted. The only other option is more death. Thank you.
Thank you, Dr. Werb. We're now going to begin with rounds of questions. We're going to start with the Conservatives with Ms. Goodridge. Ms. Goodridge, welcome back. It's good to see you.
Thank you.
You have the floor for the next 6 minutes.
Wonderful. I appreciate it, and I want to thank both witnesses for providing testimony here today. And I'm going to start out with Dr. Humphreys. I really appreciated how your entire report from the Stanford Lancet, and I'm going to pull one quote. At the same time, evidence clearly shows the folly of assuming the population health inherently improves when healthcare systems provide as many opioids as possible with as few regulatory constraints as possible. Policies that should attract skepticism include the dispensing of hydromorphone from vending machines and prescribing a range of potent opioids and other drugs, i.e. benzodiazepines and stimulants, to individuals with OUD in hopes of creating a safe, addictive drug supply and eliminating the supervision of methadone patients, i.e. converting the system to unmonitored long-term prescription on a take-home basis. I was wondering if you could expand on that a little bit, because I think this is so much the crux of the issue we're in.
So the Commission is very positive about medication-focused treatments, where people are monitored and supported, as I mentioned, methadone maintenance clinics and other opioid agonist therapies. At the same time, the Commission looked at the history of what happened in both our countries around widespread prescription of opioids given with very little supervision in the community. We were assured by the companies and by doctors that no harm would result. Prescriptions went up dramatically, and that is how this whole crisis started. So to say that now, for some reason, now if we distribute opioids without any supervision, that same thing won't happen again, really beggars belief. That contradicts our very recent historical experience, both in Canada and the United States. So we didn't recommend doing the same thing as before and expecting a different result.
And I think that that's an important piece to say, and like the entire idea where so much of where this opioid epidemic started was in fact from the Oxycontin in the 90s 2000s, and so the whole piece around diversion and the increase of 400% increase in prescription opioids. And so my question to you is, what do you think that we could do better or differently? And you kind of touched on the Alberta model, and I'm wondering if you can explain why you think Alberta is doing it right. I agree with you. I think Alberta is doing it wonderfully. I'm very proud of my province for taking this leadership, but I'm just wondering if you could give some descriptions from a medical perspective as to why Alberta is leading in this.
So Alberta has made a major fiscal commitment to treatment of all sorts. They have, extensive opioid agonist therapy. They have residential rehabilitation. They also, by the way, have very strong investments in harm reduction. What they're doing that is different from a lot of other places around the country, my country too, is first off, it is a system. All the parts are integrated together. There's a province-wide plan. There are steps of care that people go through so they can go in a pathway to come out at the end much better off than they went in. And the second thing, as I mentioned, is this optimistic idea of recovery. So, because addiction is a stigmatized condition, there are a number of people who would believe, colloquially and, in say in a cold way, well, once an addict, always an addict, they'll never change, they can't get better. And the Albertan model believes, no, that is not true, that in fact people can recover. We have millions and millions of people who have recovered, who are productive citizens, who are connected to their families, who are people we prize and cherish in the community. And setting that as the goal, as the aspiration, is extremely important, rather than saying we're just going to manage this population and we don't really expect much out of them, and at most we might be able to help them live till tomorrow, and that's all they can ever achieve. That becomes a self-fulfilling prophecy. And so I admire the fact that, when I've gone up to Alberta and visited, seeing what they're doing, that vision that every single person is capable of having a much better life through recovery than they have right now.
And you touched on it very briefly in your opening statement about how you were one of the policy drug advisors for both Presidents Bush and Obama. So you've crossed party lines when it comes to policy piece. I'm just wondering, what did you learn in those roles that you think Canada could and should adopt?
Yeah, I did do that. I'm not a politician. I'm a policy advisor. So since the science stays the science, anyone who wants to adapt it, you can work with a broad range of people, and that's what I've tried to do. What I saw in both of those administrations was the commitment to treating addiction as a health problem was profound and important. Both those presidents, although they differed in many, many ways, obviously, they both believed this is something we could handle addiction through the healthcare system. Yes, we need law enforcement when someone, does something violent or because of their addiction. But for the most part, we want people to be able to talk to their doctors about their addiction like they would talk to them about cancer or like they would talk to them about a heart problem. And they both moved our system that way. And Canada, by the way, does better than the U.S. It gives health insurance to everyone, and I think that's great. We've moved some progress towards you, and that's something we, would like to copy you in. But I think that concept, try to manage addiction as much as possible in healthcare. You don't need the public safety unless the person does something that threatens another human being.
Well, thank you. We agree completely from our perspective, at least on the Conservative benches, that addiction is a healthcare issue and it needs to be treated as healthcare in order to move forward in destigmatizing those conversations so that people can actually have those conversations with their doctor and get the treatments they need in an appropriate manner is absolutely required. So I just want to thank you for your leadership on this and thank you for being part of this committee. And if you have anything further that you'd like to add, I know I was reading quite a bit about your 24/7 recovery model. I didn't unfortunately get an opportunity to ask you any questions on that, but if you could perhaps send a brief into the committee on that, that would be much appreciated so that everyone else on the committee could learn a little bit about that model as well.
Thank you, Ms. Goodrich.
I would be happy to do that.
Thank you, Dr. Humphreys. Next, Dr. Hanley, please, for 6 minutes.
Thank you very much to both of you for your thoughtful presentations. And I want to just Briefly, Dr. Humphreys, go back to you because you have written a lot about prevention. You haven't focused on it in this talk, but I think you also talk about prevention with some sense of urgency, and including that you can't solve epidemics by concentrating on people at the extreme end. And knowing that there's a strong relationship between adverse childhood experiences or childhood trauma and addiction later in life, can you very briefly comment on the importance of upstream investments with that same sense of urgency that we're thinking about at the other extreme?
Thank you so much for raising that, Doctor. And you're absolutely right. If we look at how HIV/AIDS, how COVID were brought under control, it was through reducing new cases, and we are not doing enough of that with addiction. So the Commission recommended focusing particularly on kids in low-income environments, generic investments in their well-being. These would be things like early education programs, like nurse-family partnerships that help low-income parents to be in their first experience of birth and early child raising, as well as programs like Communities That Care, which is a very well studied program for kids a bit older, usually around 11, 12, 13, that teaches them things like how to recognize and manage their emotions, how to connect positively to other kids, how to connect to positive community organizations, whatever they may be, cultural, religious, artistic, athletic, that provide alternatives to them to substance use. And the evidence of those studies, which are very strong, shows not only that kids who get those investments have lower rates of drug use and alcohol use and tobacco use, but they're also more likely to stay in school. They're more likely to go to university someday. They're less likely to get involved in crime. They're less likely to be depressed. So making those investments, again, particularly with children who are growing up in adverse environments, is really critical, unless all of us, which I'm sure we don't want, to be having the same conversation 10 years from now. The way we get out of that is through those preventive investments.
Thank you very much. And Dr. Werb, on the prevention theme, you've written about treatment as prevention, and I wonder if briefly you've written a paper on this, and probably several, but I wonder if you could briefly comment on what you mean by treatment as prevention.
Sure. So this is an adaptation of an approach that was used really successfully in the HIV space, where basically you meet somebody's needs in terms of their needs for treatment, and you have positive knock-on effects in terms of the spread of in the case of HIV, you actually reduce the transmission of HIV among people if you provide them with medications like highly active antiretroviral therapies. So this is an adaptation of that approach slightly, but of course, drug use is a very, very different phenomenon. But essentially, what we found in this work that I referred to in my opening remarks, funded by both the NIDA in the United States and CIHR here in Canada, is that we found that people who were provided with opioid agonist treatments, who were injecting drugs, were less likely to report that they had assisted in the initiation of other people into injection drug use. And we know that injection drug use is often implicated in an increasing severity of opioid use disorder or other substance use disorders. We also found, for instance, that increasing the intensity of policing actually had the reverse effect, that people who were encountering police more often were more likely to assist people in their initiation of injection drug use. And let me just say, this is not to cast people who engage in this behavior as predators or anything like that. There are many rational reasons why people engage in this kind of behavior. But if we're looking to prevent the expansion of substance use behaviors that we think could potentially put people at higher risk of overdose, if we rely on the evidence of interventions that can help meet people's needs themselves, we find that there may be this potential knock-on effect on other people being at risk. And I'll just say on that, we have not seen the same evidence of the effectiveness of recovery-based treatment as opposed to opioid agonist treatment and pharmacotherapy treatment. And I'd point to a recent study that's coming out in Drug and Alcohol Dependence in January, but it's available online, that compared overdose mortality among people who had been enrolled in methadone and buprenorphine or in recovery-based non-pharmacotherapy treatments, and found that there was a reduced risk of overdose mortality among people who were enrolled in buprenorphine. But when we looked at people, or when the authors looked at non-pharmacotherapy recovery-based treatment, there was an increased risk compared to placebo of overdose mortality. Similarly, or just on that note, I would say that the adoption of the Alberta model, while of course, aspirational, and I think everybody in this field who devotes their time to it is aspirational and optimistic about the possibilities of people becoming well, managing their lives, and being, healthy and having good social well-being. In Alberta, after the adoption of the Alberta model in mid-2019, there was actually more than a doubling of the overdose mortality rate in that province. There was an increase in overdose mortality basically everywhere in Canada, but the rate of increase in Alberta actually outpaced a lot of other places in Canada. So I would just offer a little bit of caution on that.
Thank you, Dr. Werb. Suite, Monsieur Thériault pour 6 minutes.
And now, Mr. Thériault, 6 minutes, sir. This is of great interest to me. So I would like to be able to pick up on that discussion, what you've been saying. Here to my right, my good colleagues feel that harm reduction approaches, safe supply approaches, that this is a problem, that there are perverse or unexpected results of applying such programs. What you're saying today is that when urgent intervention is needed, an urgent intervention to prevent overdose deaths, this approach is the best that we have available to us. Now I've heard you criticize the model put forward by Professor Humphrey. Could you tell us how it is that that model, besides the data you've just mentioned, how that model is problematic?
Yeah, thanks for the question. I think it's just a matter of the evidence that is out there, right? So the evidence on recovery-based non-pharmacotherapy treatments is just not as strong as the evidence on pharmacotherapy-based treatments. There's a reason that methadone and buprenorphine are on WHO's list of essential medicines, right? Because they are the most effective approaches we have to managing people who have opioid use disorders. And, I share Dr. Humphrey's aspirational and optimistic sense of people's capacity and helping people return to, full lives after engaging in or experiencing opioid use disorders. And the fact is that methadone and buprenorphine, these programs, they seem messy, right? Because people often will begin a program, they will be enrolled in methadone or buprenorphine or another medication for opioid use disorder, and they will stop the program, they will go back on. But over time, there is just simply we don't see the evidence, the scientific evidence out there suggesting that recovery is an effective approach. I think it can certainly be a part of a comprehensive approach, but not at the expense of evidence-based pharmacotherapy clinical treatments. And I'll say one of the issues in Alberta is that the proportion of the population that has coverage for these types of medications, opioid agonist treatments or medications for opioid use disorder, whatever term you want to call it, is actually quite a lot lower than places, at least in, compared to BC and Ontario. So, when we're thinking about ways to prevent the overdose epidemic, I think we need to start with, again, where the scientific evidence is and where the scientific consensus exists. It's not to say that recovery is not appropriate for some people. It's just to say that the scientific evidence, and that's what, that's what I follow, is much stronger with respect to these types of treatments versus recovery-based treatments.
Au Québec, la docteure Marie.
In Quebec, Dr. Marie-Ève Goyer, who is the Assistant Director of the Programming for Addiction among Homeless People, so in the southern sector of Montreal, says that the whole issue of diversion in her practice, as she sees it, is very often linked, and I will quote her, freely translated, those who sell their doses say that they do so in order to be able to buy food and clothing. It's very troubling for me as a doctor to find that my prescriptions, or that with my prescriptions, I am basically fighting poverty. This has to be said openly. End of quote. What do you think of that?
Right, and this is what we've seen over and over and over again. I run a cohort study of people who use drugs in Toronto. We followed them for about 5 years. There's evidence from cohort studies of people who use drugs in Vancouver, in Montreal as well. And housing is one of the key factors that is placing people at risk of overdose. And it's interesting because we see housing in the news every day, but so rarely do we see do people put the links together between the housing crisis that is affecting all of Canada and the fact that this is also really contributing to the overdose epidemic that we're experiencing as well. It's very difficult for people to engage in treatment if they are unhoused. There's often a requirement that people, often an informal or implicit requirement, that people be housed prior to receiving standard treatment because their clinicians believe that they may be too chaotic to actually be able to, undertake or be retained in a treatment program. So, I think you've really hit the nail on the head on that. Housing goes hand in hand, and unfortunately, when resources are being allocated towards ending the overdose epidemic, this issue of housing really does not come up. And we have a shelter system really across Canada that is generally abstinence-based. And so that means that if somebody is managing their substance use through a methadone or buprenorphine program or some other program, but they're still potentially using a little bit of unregulated opioids, they're unable to stay in that shelter. And so there are some restrictions around even accessing low barrier housing that are causing people to have to make a choice between remaining on treatment or being housed.
Thank you, Dr. Werb. Next, Mr. Johns, please, for 6 minutes.
Thank you both for being here. I really appreciate it. I'm going to start with you, Dr. Humphreys. You just prescribed OxyContin for pain, as you cited, did have many ethical problems. But I think that's not really what's happening with Safe Supply. Safe Supply is prescribed to people already consuming large amounts of fentanyl, and it's monitored very closely. Dr. Humphreys, maybe you can explain what is your experience with Safe Supply programs, and have you spoken with any Safe Supply clinicians to understand their protocols, or are you basing your statements on others' anecdotal statements?
That's a fair question. I have talked to some people who do this. We do not have this in my country, so you would be right to say I'm looking at this from far away. We do, though, of course, have the experience of opioid prescribing. When it was OxyContin, many of those people getting it were addicted and did addict other people. If we wanted to know if that phenomena had somehow stopped for some reason with Safe Supply, I don't know why we would assume that if we did, what we would do is you would run something that has not been done. There's nothing in the literature of this sort. You would run urine screens on every single person every day on Safe Supply, and any day when they did not have the drug supplied in their urine, you would ask them, where did that drug go? And you would find that person and see if they overdosed, fatally or non-fatally, or whether they initiated an addiction with that medication. And that has not been done. And that's what I would do if I were really monitoring this closely and concerned about harms to the community. We were very casual about that possibility for a very long time with OxyContin, and we regretted it. And because that has not been done, that frankly worries me that we're doing the same thing again.
Dr. Humphreys, there's actually been over 20 published studies. Have you, what published peer-reviewed literature
Yes.
have you read to understand
read,
safer supply?
What I just said is based on those studies. They are studies of people enrolled in the programs. There are not studies that track community effects of diversion, which is what you would do is find out when they did not take the medication, who took them, what happened to them, did they overdose, fatally or non-fatally, did they initiate an addiction? That is not in the literature, and I've read all those studies. There is not a study like that.
I'm going to come back to you in a minute here. Dr. Werb, I'm going to go to you. What have you observed in terms of, safe supply in terms of how it's being described in the media or by critics versus how safe supply is actually operated? And can you tell us where the media and critics are misrepresenting the evidence on safe supply?
Sure. So I don't know if anyone is willfully trying to misinterpret or misrepresent anything. I will note that I'm the principal investigator of a national evaluation of safer supply pilot programs in Canada that's funded by Health Canada and run by Canadian Institutes of Health Research. I can speak a little bit about that. I think, one of the issues that that I find troubling is that there is this conflation of quite a number of different approaches into this idea of safer supply or this term of safe supply. So sometimes when people are talking about safer supply, they're talking about regulating the currently unregulated drug market, which I would be happy to talk about. Sometimes they're talking about prescribed clinical guidelines, which are in place in British Columbia. Sometimes they're talking about pilot programs like the ones that our national evaluation is studying, which are integrated into existing harm reduction and social care programs, right? And all of these programs are very different. In these programs, generally, safer supply is a component of a broader, comprehensive approach to meeting the needs of clients or members or patients. All of these programs refer to their these people differently. And I would say that, I would echo Dr. Humphreys that the evidence is still emerging, right? These are programs that have been in place only for, 2 to 3 years. But I really want to make the point here that the prescribed safer supply guidelines in BC are quite different. Like, these are just the opportunity for clinicians to provide a particular type of medications for a particular condition among their patients, which are different than these wraparound integrated pilot programs.
So we know OxyContin is not safe supply. OxyContin caused a fraction of overdose deaths compared to fentanyl. We saw overdose deaths in the U.S. grow to 275% between 2016 and 2021, more than Canada, which doubled. Alberta, we can look at their record. I mean, April, they had a record amount of overdoses. Lethbridge, they've already surpassed it by August this year, last year, which was a record year. They've closed their safe consumption sites. Can you talk about the effectiveness of harm reduction interventions like drug checking, supervised safe consumption sites, how many lives are saved?
Sure, and I'll say, in the case of Alberta, just to note that only about 5% of fatal overdoses have prescribed overdoses implicated in them. Or, pardon me, prescribed opioids implicated in them. I'll just echo what I said earlier around supervised consumption sites, right? Like, we have worked with the Chief Coroner's Office of Ontario to map overdose mortality across the city of Toronto and year over year. And what we found was that, and it's pretty remarkable. Up to 5 kilometers away, we saw about a 2/3 reduction in the rate of overdose mortality across neighborhoods. And so, we're trying to figure out why that is, because that's a really powerful effect.
Thank you,
We
Dr.
think that, beyond people's access to these programs on site, that they're also hubs of harm reduction services, right? These are places
Thank
where
you,
people
Dr.
feel
Wood.
safe going, where they can pick up naloxone,
Thank
where
you,
they're
Dr.
provided
Wood.
with safer education about
you.
how to avoid overdose.
We're
and
out of
that's
time.
really, really critical.
We're out of time for this round of questions, but I'm sure there will be further opportunities to reinforce the point. Mr. Majumdar, please, for 5 minutes.
Oh, thank you very much, and I'd like to thank both witnesses for appearing before this committee. I'll direct my first questions to Dr. Humphreys, if that's okay. In our committee, there's been a lot of discussion about the Portugal model, often held up as a beacon of hope for Canada and for others. Based on the survey of literature that you've been able to take into account, is this comparable, the Portugal model, to Canada? Is this comparing apples to apples?
Well, I should say I've read that literature. I've also spent a lot of time in Portugal and know that actually I was just talking to the director of that program a week ago. Portugal, first off, is going through a hard time right now. I think overdoses are at about a 12-year high. But at least early on, they did seem to have some benefits from their great expansion of services around addiction and HIV. Their HIV rate among people who use drugs dropped, and that was certainly very positive. They do also have dissuasion committees, which are able to put some pressure on people who have problematic drug problems to change their behavior. And that is something that's often forgotten when people talk about the Portugal model. They think it's a sort of libertarian, everyone does whatever they want, but that is really not the case. A big difference that goes beyond policy is the cultures are very different. Portugal is different than both the U.S. and Canada in that it is a country that was very strong Catholic history, a very communitarian society, a lot of social control on behavior. So when they backed off from legal control, there was still tremendous social control from families, from communities, and disapproval of drug use, which is less common, particularly in the Western U.S. and Western Canada. And so places that have tried to copy that approach, like, for example, the city where I live near, San Francisco, we see this in Portland, Seattle, Vancouver, haven't had the same results as Portugal. And that could be that, same policies, different cultures, you get different results.
Thank you for that. Maybe if I could pick up on one of the items you mentioned, which was the increased overdoses in Portugal. Could you describe what the origin story for that might be?
There's a couple theories about it. I mean, one is the financial crisis hurt their services, so they did cut services pretty dramatically. That cannot help. It is also true that the EU is open, so people can move now from all over the EU to different places. So over time, places that have liberal drug regimes may attract people who like to use drugs or want to be able to do so without any hindrance. We see that certainly in San Francisco, I can say that for sure. So that may also have made their drug problem more complicated as people moved in to use drugs.
Just a quick question. They're not dealing with the fentanyl crisis like we are in Canada, are they?
Not yet.
Not yet.
But fentanyls, nitazines are arriving in Europe. It was just a big bust the other day in Britain. There's been a few cases around Europe. All my European colleagues are quite frightened about the arrival of synthetic opioids of some form in the coming 18 months because the Afghan heroin supply is being restricted by the Taliban right now.
If I could bring that into Canada then, in your professional opinion, do you believe that the current government's approach on safe supply policies are working?
No, I wouldn't expect them to work because it's essentially a replication of the policies we had in the aughts of distributing opioids in the community and trusting because they are legal and because they are of known quantity that nothing bad will happen. It will take a while to see that. I mean, the focus, I realize discussion is on overdose, but you have to think also about addiction. So if you're generating new cases of addiction, that will not show up in overdoses for 5 or 10 years, but it could definitely be happening. That is exactly what happened during the era of OxyContin. And I would point out, by the way, the main drug being used, hydromorphone, is a very strong opioid. It is not a low-strength drug by any means. It can certainly be addictive, particularly to novice users. So that's why it can be very important to evaluate whether any of those drugs are being diverted to, for example, people who are younger and this may be their first drug experience and getting access. Whether or not that's happening is something I think should be studied.
Next, has there been any evidence from jurisdictions to support the claim in which safe supply contributes to a positive result, less crime and disorder, more people transitioning to the workforce, fewer drugs, flooding illicit markets? Have you seen any evidence of that yet?
Brief response.
So in the
Dr.
literature,
Humphreys.
In the literature, there's certainly people who are on safe supply report, appreciating the program, valuing the program. They still do use a lot of illicit drugs. I don't think there's anything linking it to broader community effects like employment and the drug supply or addiction and overdose among people not enrolled in safe supply.
Thank you. Next, Dr. Pawlowski, please, for 5 minutes.
My initial question to Dr. Humphreys. So I share a bit of skepticism about the safe supply position for the same reasons that you've already talked about. However, do you not think it's possible that there is a certain subset of population that would benefit from safe supply, in that some people are dependent on narcotics and perhaps dependent on a fixed level of narcotics, and the fact that they can't get the narcotics and they go buy it on the street, where often it's contaminated with fentanyl or carfentanil. So do you think it's possible that although perhaps in general and for everybody, safe supply perhaps is not a good idea, that there may be a subset of population where it in fact is a good idea?
Thank you for that question, Doctor, because it gives me a chance to clarify something that I think has been even misunderstood perhaps, which is the Commission is very positive about opioid agonist therapies, like methadone, like buprenorphine. In Canada, you also have slow-release oral morphine and hydromorphone, which we don't have. You have diacetylmorphine, too. We're very positive about the effects of all those, and for multiple reasons. Yes, people avoiding the illicit supply, but also because of the stability they provide, the links they provide to other health services. So all those things are true. When you start distributing, though, without any real monitoring in a community, you have to start thinking about not just that person, and even if they benefit a bit, but what about everybody else? And if those drugs are going out and harming other people, the net effect could be negative, even though there is a particular person who benefits from that. And that's why doing very careful audits of where are these drugs actually going, in other words, looking at the people around the people in these programs, is really important before we make a judgment, which you can't really make just based on what that person says and experiences.
Okay, I'd like to turn to a second issue, safe injection sites, and I'd like to ask both of you about this. I think you both agree on these, that this reduces mortality. And Dr. Werb, you talked about the potential closing of 2 safe injection sites in Northern Ontario. I'm the Member of Parliament for Thunder Bay Rainy River. I would say, and I wanted you to address this issue, there's a very heavy component of NIMBY with safe injection sites, which is not in my backyard. And I have to say I have a certain amount of sympathy for it. Would I be happy if a safe injection site opened right next door to where I live? Probably not, and especially when you combine it with decriminalization and what you tend to see is around those sites a kind of accumulation of people selling drugs, and very rapidly those become not very desirable parts of town. So although in general there seems to be good evidence that these are a good idea, how do we address the problem of the crime and social problems that tend to accumulate around those centers? Maybe I can start with Dr. Werb.
Sure, thanks. It's such a good question. And I'll just note that, these sites are implemented in places where there is drug-related activity, right? That's generally where they are placed so that they can benefit as many people as possible. So I think it's important to remember that. We've been looking at this question. In Toronto, there was some violence, unfortunately a fatal shooting, less than 100 meters from a certain supervised consumption site. So we worked with the coroner's office to analyze spatial data on homicides, fatal shootings that could be potentially related to drug market activity across 10 years in Toronto. And what we found is that there's no association between the location of homicides and the location of these sites. So on that, at least, I think there's evidence from Toronto suggesting that these aren't necessarily seeming to attract increased fatal violence. We're still going to look at other measures of violence just to see whether they agree with our initial analysis. But I'll just say that I also understand people's desires to ensure that the programs in their communities are run and managed as well as they possibly can be. And I fully understand people being concerned about their public safety. What I found galvanizing is that the conversation that has happened, at least in Toronto, around this issue, has not been hasn't gone to the extreme of saying we need to close these sites. A lot of the conversation is how do we design them? How do we better manage these sites? And unfortunately, what happens is these sites are designed for the number of estimated clients that they're going to have, and then budgets are often cut and resources aren't provided for them to provide the services to the number of clients that they actually have. So you're starting at a deficit where you've got waiting lists, people show up, then they leave without actually being able to access the services. So I think a key component here needs to be resourcing these services sufficiently so that they actually can meet the needs of their client base.
Thank you, Dr. Werb. Suite, Monsieur Thériault, pour 2 minutes et demie.
Mr. Thériault, 2.5 minutes. Yes, in the same article, written by Jessica Nadeau of the 9th of December last, so that's pretty recent, in the Devoir, Dr. Goyer states regarding what's available in the illicit drug market, she says, the elephant in the room, the illicit drug market, creates substances that are more and more complex, more and more dangerous, and this is increasing at a phenomenal rate. I've never seen this before in my career. The illicit market is creating substances that don't even exist in the medical pharmacology. Fentanyl, powder fentanyl, I have Ativan. You create a substitute with caffeine in it so it won't cost as much. But now it's much more advanced. They're now mixing substances. It's a real approach that has never been observed before, a complexity now to manage the overdoses and the treatment. We don't even know what we're treating. End of quote. What do you think of that statement? Have you observed something similar?
Yeah, so look, the evolution of the unregulated drug market is predictably unpredictable. And I think we need to trace this back to the late 19th century, where we had opium, then laudanum, then heroin, then fentanyl, then carfentanil, then nitazene class opioids. Every step of the way, as there's been more pressure placed on drug markets, unregulated drug markets have adapted and they've evolved. I mean, it's like any other market. I think of the smartphone market, right? There's pressure for evolution in markets. That's why we started with giant phones that couldn't do anything, and now we've got smaller and smaller phones with incredible computing power. And unfortunately, what we've got right now is pressure from law enforcement and seizures that is incentivizing innovation on the part of drug trafficking organizations. And if we want to address overdose in a meaningful, structural, long-term, and sustainable way, I think we need to look at the source of the innovation that's happening in the unregulated drug market and think about structural ways that we can actually apply some stasis to the market.
Thank you,
leave
Dr.
it there.
Werb. Last round of questions for this panel will come from Mr. Johns for the next 2.5 minutes.
Thank you, Mr. Chair. Dr. Humphreys, are you aware of the data showing overdoses and infections increased exponentially in 2013 or so with the introduction of fentanyl? And are you aware overdoses and infections occurred with OxyContin, but at a fraction of the rate of fentanyl?
Fentanyl is definitely more likely to cause an overdose than OxyContin. But since we're also concerned about addiction, far more people got addicted to OxyContin than to fentanyl. Both things are desirable to avoid.
In terms of the protocols and structures, they're wildly different, in terms of safe supply, and Oxy. They're daily dispense, monitored weekly. I guess I'm wondering how you can compare the two in terms of safe supply protocols and structure. And I'll just state that methadone retention rates are 50% at 6 months. Buprenorphine is 40%. Safe supply retention is greater than 90%. Are you aware of these impacts? And have you, because you stated no protocols to monitor diversion earlier, that you haven't seen any. And I know the safe supply clinics have heavy amount of monitoring for diversion. So I'm just concerned about your knowledge around safe supply, if that's complete or not.
What I said, and there is no evidence to contradict, is what no one has done is when people test negative for the drugs they're provided, to go find the person to whom those drugs went and assess their well-being. That's the kind of monitoring that you would need to do to determine whether or not these are doing community harm or not. And that has not been done. There's no study like that in the literature. That's why I call attention to it as an area for audit.
Can you talk about how many times it takes people to go through recovery treatment before they stay sober long term? Like, what is the success rate of people staying sober after 1 year and 5 years? And after treatment, what happens? What are people supposed to do if there's no housing?
Yeah, I mean, I can. Oh, is that for you, Dr. Humphreys?
That's for Dr. Werb, yeah.
Yeah. I mean, I can say that there's good evidence suggesting that people, on average, engage in, say, a methadone program 5 to 7 times, right, before they're able to manage their substance use long term. There's evidence suggesting, on the recovery side, for example, there was a randomized clinical trial of buprenorphine and some counseling versus just counseling and no pharmacotherapies. That found that the mean abstinence rate for the counseling group was 5%, compared with 43% in the buprenorphine group. So again, there's just really good evidence to suggest that pharmacotherapies can provide a more effective abstinence compared to recovery-oriented non-pharmacotherapy treatments. And again, I would just reiterate that because of the kind of catch-22 that happens where people can't find housing because they're using substances but can't access treatment because they don't have housing, this is a major, major issue that is going to prolong the life cycle of this overdose epidemic.
Thank you. Thank you, Dr. Werb. Thank you. Yes, yes.
Possible, I know Mr. Werb talked earlier about a study from the Chief Coroner Office of Ontario to map out overdose mortality in the radius around supervised consumption sites. Would it be okay with the will of the committee to ask him to table that report to the committee within 2 weeks? Would that be possible?
Thank you. Thank you, Mr. Johns. You took the words right out of my mouth. Dr. Pawlowski?
Could I ask both witnesses to please submit any studies which they think are particularly relevant to this study?
I'm redundant here now. So let me just say thank you. This has been a fascinating discussion. We very much appreciate you being here with us and sharing your expertise. There was easily enough interest and enough questions to keep you here longer, and that's probably the reason why we'd like to see a follow-up in writing. So once again, thank you, and I wish you all the best of the holiday season. Colleagues, we're going to suspend to allow the next panel to get set up. So we're suspended for 5 minutes. order pursuant to Standing Order 108 Sub 2 and the motion adopted on November 8th, 2023. The committee is resuming its study of the government's advance purchase agreement for vaccines with Medicago. I'd like to welcome our witnesses representing Medicago, Inc., Toshifumi Tada, President and Chief Executive Officer, and Sarah Marquis, Vice President, Legal Affairs and Corporate Secretary. Thank you both for taking the time to appear today. You have up to 5 minutes for an opening statement. Welcome to the committee. You have the floor.
Thank you, Mr. Chair. First of all, ladies and gentlemen, I'd like to appreciate this invitation to attend the House of Commons Standing Committee on Health today. My name is Toshifumi Tada, President and CEO of Medicago. I'm accompanied today by Sarah Marquis, Vice President, Legal Affairs and Corporate Secretary of Medicago. Medicago was a Canadian biotechnology biopharmaceutical company specialized in discovery, development, and commercialization of virus-like particles, we call it VLPs, using plants as bioreactors to produce protein-based vaccine candidates. Medicago's VLP technology was born out of a research partnership between Laval University and Agriculture Canada in 1997. Medicago's technology evolved from research and development to having its first VLP vaccine approved by Health Canada in February 2022. It was the first plant-based VLP vaccine approved for human use in the world. In the clinical trials, our vaccine was found to be 71% effective against symptomatic infection and 100% effective against severe disease caused by coronavirus. These studies were conducted while there were multiple variants in circulations. I want to clear that these results could only be achieved with tireless dedication of our employees and scientific achievement and expertise developed in Canada. Medicago is very proud of this scientific achievement. Although the science was a success, we experienced challenges in transforming to commercial scale-up production. Our experts believed we could fix the issues, but it would take time. But at the same time, however, the vaccine landscape was evolving very rapidly with more and more variants arising. We assessed that significant additional research and development investment would be needed. This is why our shareholder, Mitsubishi Chemical Group, made the business decision to cease the operation of Medicago. This was a very difficult decision to make on both business and human level. Medicago has been in Quebec for more than 20 years, and at the time of Mitsubishi Chemical announcement, we had nearly 600 employees, both in Canada and the United States, with 378 employees in Quebec City. The company had strong ties to the local community, and our employees believed in Medicago's technology and its public health mission. As a part of the wind-up activities at Medicago, we ensured that all employees received the full amount of compensation they are entitled to. In addition, we provided full support and outplacement services, including organizing job fairs for our employees within a collaboration with Quebec government to help our employees find their new employer. We also worked with financial and legal advisors to terminate our agreements with our service providers, to settle our debts, to sell our business operation and assets. This led to several transactions, two of which were with the government of Canada. The first one is advance purchase agreement between Medicago and PSPC, signed in November 2020. Under this agreement, Medicago had received a non-refundable advance payment of $150 million for initiating manufacturing of the COVID-19 vaccine at risk. This agreement was terminated by mutual consent in June 2023. Medicago was released of its obligation as it met all the terms under the agreement. Second transaction was the Strategic Innovation Fund, or SIF agreement with ICED. This was recently terminated. Under this agreement, Medicago was awarded contribution offers for the development of our COVID-19 vaccine and establishment of large-scale manufacturing facility in Quebec. As part of the termination agreement, we reimbursed amount owed to the Canadian government, which included $40 million in cash and transfer of our key research and development assets, such as our manufacturing plant, pilot plant, intellectual property assets, and equipment to Aramis Biotechnologies, which is a new local company established by former employees of Medicago. Now I'll be happy to answer the questions the committee may have at this point in time, and it's possible that I may ask my colleague Sarah Marquez to answer some questions that fall within her field of expertise. Mr. Chairman, that concludes my opening statement. Thank you.
Thank you, Mr. Tata. And we're going to begin now with rounds of questions, starting with the Conservatives for 6 minutes. Mr. Perkins, please.
Thank you, Mr. Chair, and thank you, witnesses. Mr. Tata, how many contracts were signed with the government? There was the one for $200 million initially for both the development of the vaccine and some plant improvements. What other contracts were signed?
Yes, we have two contracts, APA, Advanced Purchase Agreement with PSPC. Second, SIF agreement with ICED. Okay. Those are the two contracts we have with the federal government of Canada.
So on the first one, which was SIF, the SIF program from ICED, that required, that was for $200 million, and I believe I've read reports that in the end only $173 million was used. Is that correct, or was the full $200 million used?
That contract contributes up to $200 million to Medicago to support our development of the COVID-19 vaccine and the establishment of a manufacturing facility.
How much was used of that? All of it? Did you receive all $200 million?
I don't comment in the detail yet, but the agreement is up to $200 million.
You won't tell this committee, the Parliament, how much money the Government of Canada actually in the end transferred to you?
Yeah, it is. I have a confidentiality obligation, sir.
Well, it's been reported as $173 million, but since you won't, I'll leave it at $200 million. So in addition to that, you had the purchase agreement for, I think it was 76 million doses of the vaccine, which is estimated to be, if it had been delivered, about 1.5 billion.
That is another agreement of APA with PSPC, which says 20 million doses ordered, and government has an option to order additionally 56 million.
So for 76 million, and again, you'll probably say it's confidential, but the price that is commonly out there is $20 a dose, so 1.5 million. So the recent announcement by the government to pay Medicago $150 million for, I believe, no doses delivered is out of that contract, correct? Their obligation, the government's obligation from that contract?
First, $150 million is non-refundable advance payment, which actually used to manufacture vaccines at risk. This was an original concept.
But you didn't deliver a single vial of vaccines to the government of Canada, is that correct?
It is correct. We didn't deliver anything, any doses.
The contract was signed, the first one for the SIF contract in October 2020. 5 days later, the advanced purchase and sale was done for 76 million doses on a vaccine which you hadn't yet invented. And the government, which I know is not your area, had already, through a series of about 3 months, had signed other contracts for 190 million doses of other vaccines, of which they only used half. So when you got approval, and congratulations on getting this great scientific breakthrough of a non-mRNA vaccine with such efficacy, when that was approved by Health Canada in February, I believe it was 2022, was the government not in an obligation to now start purchasing those, that production?
As you understand correctly, we obtained approval of the COVID-19 vaccine in February 2022. The APA with PSPC initially said our delivery of the 20 million doses is up to the end of 2021. Because of the delay in the approval, we negotiated in good faith with the PSPC, and we agreed to amend the agreement in which delivery of the first 20 million doses can be made by the end of 2022, which is 10 months after the approval.
Right, and so why didn't any of those doses flow to the government of Canada after it was approved?
This way, after the approval, we faced the challenges in transitioning to a commercial scale-up productions. We started to work on it, and our experts believed we would be able to fix it, but we knew it would take time.
The health minister here at committee last week said the reason was primarily because they had enough doses of other vaccines.
Yeah, because I haven't finished
it. Let me finish. Said that they had enough doses of other vaccines from other manufacturers, and they didn't need this vaccine anymore, and that they actually had another non-mRNA vaccine that they had bought and acquired. Is that correct?
Yes, I will answer that one. While we work our internal challenges, we started to observe market evolving a lot because we started to see a lot of new variants arising that made our vaccine irrelevant because market demand shifted to bivalent vaccine, including Omicron, which is not the case for our vaccine.
So the delay by Health Canada made made your vaccine no longer relevant to the subsequent strains of COVID.
Therefore, we understand the Canadian government needed to...
Just hang on, I'm speaking.
Go ahead.
And so, the result of that is $150 million of taxpayer money had to flow to you and to Medicago for actually a vaccine that was now outdated. And that's why they didn't receive any vials?
At that time, Canadian government needed to readjust their vaccine inventory positions in light of the government evolving, right? So they decided not to take a vaccine given the market situation they faced then. $150 million advance payment was non-refundable because it was funded to our manufacturing of the vaccine at risk, sir. We purchased raw materials. We produced many batches. We hired additional workforce to support increased capacities before the approval was approved.
That's all the time for this round.
Therefore, again, I want to confirm that $150 million advance payment was to finance our manufacturing at risk before the approval was given.
Thank you, Mr. Tada.
Yep.
Next, we're going to go to Ms. Sidhu, please, for 6 minutes.
Thank you, Mr. Chair. Thank you, Mr. Tada, and Ms. Marquise being with us. My first question is, Mr. Tada, critics of our deal may be concerned that this deal was lost money, but that is not true. We saw the development of a vaccine from scratch. We saw growth of a sector and development of a talent pipeline. Can you speak a little bit about what the values of the investment in Medicago was and the importance of the government participating in de-risking these kind of investment?
Yeah, thank you very much for the question. Thanks to the support and contribution from the government, we advanced technology and science that was born in Canada a lot that resulted in our approval of the COVID-19 vaccine. This is the world's first plant-based VLP vaccine for human use. Together with our shareholders' investment, government contribution was also helpful to provide and advance these technological and scientific achievement. So we don't call it's a waste, but we advanced and we showed significant science advancement for Canada. Given that, given the situation we faced with, we discussed with an ISED and we agreed by mutual consent to terminate the agreement. We settled the agreement by repaying back $40 million in cash and transfer of our key R&D assets, including pilot plant, IP, and assets and equipment to 8 Canadian companies. So our IP will remain. in Canada, in the sense.
Thank you. And Medicago recently reached an agreement with the Armies Biotechnology, a Canadian company based in Quebec City, to transfer key Medicago research and development assets, intellectual property, and equipment. Could you let us know exactly what medical research was transferred to this Canadian company? And you already told that the medical employers are working with the Armies, right?
I have a confidentiality obligation not to disclose the detail of the transaction with Aramis, but I can confirm that we transferred our R&D manufacturing pilot plant in Quebec City, equipment, and our IPs at the request of ICED.
Thank you. And we all know Medical had a really promising research on a unique COVID-19 vaccine. These were plant-based vaccine that didn't contain eggs. Can you expand on why plant-based vaccine technology is important, how this kind of technology could be used for future vaccine development?
Thank you very much. We could not successfully launch COVID-19 vaccine under the very unprecedented pandemic situation, but we still believe the scientific potential of these plant-based vaccines. For example, COVID-19 vaccine, dominant COVID-19 vaccine are messenger RNA vaccines, but having an alternative such as protein-based vaccine, including our plant-based VLP vaccine, would benefit for the human people's health because it offers another alternatives. So we still believe that we still believe in our technologies. Unfortunately, we are winding up operation because of the business decisions, but because we do have scientific achievement and we do have our people or employees who made it happen, so hopefully these technologies can remain in Canada for the future. Further scientific expansion.
Mr. Chada, back to the agreement question again. This agreement enables Canada to maintain an important domestic assets in the Canadian life sciences sector, diversifying the national pipeline of vaccine technologies, and providing Canadians with a safe and effective platform that can complement existing and future vaccine production capabilities. This is why we worked closely with the MCG to ensure that Medicago's science, intellectual property, and core assets remain in Canada, and that it is competencies and capabilities are retained in our country. Could you speak to importance of retaining intangible assets like IP in Canada?
Yes, thank you very much. Our shareholder, Mitsubishi Chemical, had to make a difficult business decision. This is the business decision they could make. But they wanted to be as collaborative as possible with the Canadian government so that we can have kind of win-win solutions. As a result of that, we agreed with ICED to terminate the agreement, but we settled by transferring our key assets we had around the pilot plant, equipment, and IP to a Canadian company at the request of ICED. So this is, I believe this fulfills Canadian government requirements, and we also wanted to make this business decision executed as smooth as possible.
And one last question on the plant-based production technology. Are there any other ways this technology can be used to fight other diseases? Was your team working on any other drugs or vaccines?
Medicago is winding up now, so we are not working on that around at this point in time. But hopefully, if Aramis continues to advance technologies leveraging our medical achievement, hopefully they can find some new solutions, so new potential, new applications of the VLP, plant-based VLP technologies.
Thank you, Mr. Tada. Ms. Sidhu, suite Madame Vignola pour 6 minutes, s'il vous plaît.
Ms. Vignola, 6 minutes. Thank you very much, Chair. Medicago had a plant in North Carolina. Is the technology used there, was it transferred as well to Aramis Technology in Quebec City?
Thank you for the question. The factory we have in North Carolina is actually leased assets, so it's not a part of a transaction with Aramis.
Thank you. Merci.
Thank you. Medicago specialized at the outset in H1N1 vaccines for influenza and even the Ebola virus. Had Medicago focused only on those viruses during the pandemic, would we be in the situation we're in now, being a factory that's empty in the city of Quebec and that's worth a couple of $1 million and a company that was wound down?
Yes, previously we worked on those viruses before. Now, because of the business decision by our shareholders, we are winding up and we transferred some key assets to Aramis. So hopefully, I'm not in a position to make a comment on Aramis business plan and strategies, but they might or may not take those projects as their strategies.
Ma question était hypothétique.
My question was hypothetical. If Medicago hadn't stepped forward to help the government of Canada with all the risks that that involved and had continued rather to focus on the vaccinations that it had already developed, would we be in the position we're in now?
It's very difficult to answer the hypothetical question, so I'm going to refrain from commenting on that. Sorry for that.
Merci.
Thank you.
Est-ce que Mitsubishi...
Why did Mitsubishi Tanabe Pharma Corporation take an interest in Medicago at the outset?
Mitsubishi Tanabe Pharma Corporation acquired 60% Medicago in 2013, so 10 years ago. Vaccine business is one of their core focus areas, so they wanted to strengthen their business capabilities, incorporating Medicago's technology, which is plant-based VLP vaccines.
Okay. Est-ce que Mitsubishi Chemical...
Very well. Was Mitsubishi Chemical Group concerned about the presence of Philip Morris as a shareholder?
Philip Morris was shareholder of Medicago even before Mitsubishi Tanabe Pharma acquired 60%. So based on the discussion between Philip Morris Investment and Mitsubishi Tanabe Pharma, they agreed to form a joint venture at 60-40 shareholding ratio.
Donc, aucune préoccupation.
So no concern about that at all?
I don't know whether they had a concern 10 years ago or not.
Est-ce que Medicago a tenté de se...
How did Medicago attempt to distance itself from Philip Morris in 2020, and why did it wait until 2022 to do that?
First, a shareholding structure was a topic discussed between two shareholders. Medicago itself was not involved in the shareholders' discussion, so I'm not in a position to make a comment on that aspect.
Vous avez dit dans votre déclaration que...
You stated in your opening statement that the vaccination worked 70%, was effective for asymptomatic COVID, and 100% to prevent severe COVID. So I understand, and correct me if I'm wrong, that the only reason why the World Health Organization did not authorize the vaccination for emergency use was because of its shareholder.
That's our understanding. It has nothing to do with the vaccine's efficacy or quality.
La technologie par les plantes.
Plant-based vaccine technology. Some media has said that the tobacco plant was used to produce the vaccination. Could you, and of course I'm not a scientist, I'm not speaking to a scientist, but I imagine that you have some basic ideas about the production methods, the difference between the plant used by Medicago and the plants used by cigarette producers. So what's the difference between Nicotiana benthamia and Nicotiana tobacco?
First, I want to clarify that we use plant called Nicotiana benzamiana. This is relative to tobacco leaf, but it's quite different from the tobacco you smoke. And our vaccine contains no tobacco or nicotine product.
Merci beaucoup, Monsieur Tada.
Thank you very much, Mr. Tada and Ms. Marquis. I think that winds up my time. Yes, it does. Thank you.
Please, for 6 minutes.
Yeah, I try to get some answers out of this as well on a similar track. On December 29th, 2022, CBC News reported that the tobacco giant Philip Morris International had divested all its shares from Medicago. Now, in a statement, Philip Morris spokesperson David Fraser said the company decided that this was, quote, the most appropriate way forward. So before the decision, Philip Morris owned 21% of your company's shares. Can you confirm how Philip Morris International was compensated for its Medicago shares?
Thank you for the question. I understand the result was that share transfer from Philip Morris Investment to Mitsubishi Tanabe Pharma was a result of the discussion, intensive discussion between the two shareholders. And Medicago was not involved in those discussions, so we don't have any knowledge to answer your question.
So you have no idea how Philip Morris International was compensated?
No, we don't know. It was between the shareholders.
Okay. Mitsubishi Chemical Group's consolidated financial results for the fiscal year ended March 31st, 2023 notes the following, quote, that MCG has determined that it will not pursue the commercialization of the VLP vaccine. In addition, MCG judged that it was not viable to continue to make further investment in the commercialization of Medicago's development products and decided to cease all of its operations at Medicago and proceed with an orderly wind-up of its business and operations. Consequently, since the investment has become unrecoverable, the carrying amount of Medicago's vaccine manufacturing equipment and goodwill related to its business and operations was reduced to the recoverable amount, end quote. So can you outline why MCG came to the determination that it was not viable to continue to make further investment in the commercialization of Medicago's development products?
Yeah, thank you for the question. Two axes. First, after the approval, we faced internal challenges in scale-up production commercial, and we knew that it would take time to fix the issue. That's first. Second, while we are fixing the issue, we started to observe COVID-19 vaccine market is evolving quite a lot, and market demand shifting to bivalent vaccine, including Omicron strain, which our vaccine did not contain Omicron strain. So we thought additional R&D investment would be needed to catch up. At the same time, we negotiated with the PSPC that because of the market's change, PSPC would cancel their order because of their inventory position and the virus is strain in circulation. Given those, we understand Mitsubishi Chemical reviewed these situations comprehensively and decide further investment will not make a business case for them.
Okay, can you confirm the recoverable amount for Medicago's vaccine manufacturing equipment and goodwill related to its business?
I'm not in a position to comment financial recoverable amount, but we can understand that our shareholders have invested in Medicago almost $2 billion so far.
Okay. Philip Morris International's 2022 annual report noted the following, quote, in 2021, our equity method investee Medicago Inc. initiated additional rounds of equity funding in which we did not participate. And as a result, our share of holdings in Medicago Inc. was reduced from approximately 32% at December 31st, 2020 to approximately 23% as of December 31st, 2021. The ownership dilution resulted in a 4-cent per share of favorable impact to diluted EPS and income of $55 million to equity investments and securities income loss net in the consolidated statements of earnings for the year ended December 31st, 2021, end quote. At this committee's meeting last Wednesday, Health Minister Mark Holland claimed that PMI's minority position that was held in Medicago did not advance the interests of either nicotine or tobacco, given that this ownership dilution had a positive financial impact for Philip Morris International, contributing to a net income of $55 million for the year 2021. Is it accurate to claim that Philip Morris International's minority position in Medicago did not advance the tobacco company's interest?
First, I can't comment on how interesting Medicago is to Philip Morris investment. That's their investment decisions. But I can confirm that they are minority investors, and we didn't have any tobacco research, whatever, with Philip Morris investment. We use Nicotiana benzamiana as a plant, which is relative to tobacco leaf, but it's not tobacco leaves. And our relationship with PMI is nothing more than minority shareholder.
Okay. The profit could certainly float back to the company so that they could advance their interests. The government invested $173 million in Medicago in 2020 to help your company develop and produce its plant-based COVID-19 vaccine, Covifense. Can you confirm if the government of Canada received any equity in exchange for its investment in Medicago?
That $173 million is a contribution under CIF agreement, and there was, so that's all about it. So we can't.
So you can't tell us whether there's an equity?
We don't discuss the detail about the contract, but I am just telling that $173 million in the contracted in 2020 was the contribution by the ICED to help Medicago's development of the COVID-19 vaccine and establishment of the large-scale manufacturing facility.
I think it's really hard for this committee to get a lens without that answer.
Suite, Monsieur Deltel, pour 5 minutes, s'il vous plaît.
Mr. Dettel, 5 minutes. Good day, Ms. Marquis, Mr. Tada. Welcome to our House of Commons. I am an MP for Quebec City. I was very proud of Medicago, and I think it's very unfortunate what happened over the past few years, especially given that the World Health Organization refused to recognize the vaccine that you worked on. So isn't that disappointing? It was written black on white in international treaties that the World Health Organization would never recognize the work of Medicago. Let's remember that the Framework Convention on Tobacco Control of the World Health Organization specifies that parties will ensure that their policies will not be influenced in any way by the tobacco industry. And, of course, Canada was one of the 151 signatories. In 2008, Philip Morris became a minority shareholder of Medicago. At that point in time, did anyone, either within the government or in 2008 in the company, ring a bell to say, look, this is an emergency, be careful, the World Health Organization will never recognize our work? Yes or no?
Questions. No, we have been in a conversation with WHO because we want to prepare ourselves to make an application under the pandemic situations. After we make an application, they rejected because of the tobacco connection reason. But the situation is this way. When they review the application, they already have other vaccine candidates. Therefore, we understand they made their own decision based on the situation they faced with at that point in time.
Mr. Tada, black and white, we know that the World Health Organization would never recognize work carried out by any company with a shareholder that was a tobacco company, and that was in 2008. So in 2020, you announced your work on the vaccine. So in October 2020, the Government of Canada provided you with taxpayer money, $173 million of it. Did anyone in your company point out to the government that given that you had a tobacco minority shareholder, the World Health Organization would never recognize your scientific work, yes or no?
We did not specify that the WHO may or may not approve our vaccine because of the reason the Canadian government. First, the fact that PMI was our minority shareholder was already public information. Second, WHO has a kind of exceptional treatment under the pandemic situations. So we discussed with the WHO to prepare for our applications. But when they reviewed, the situation got changed.
So what did they say at that time when you had that kind of discussion with the government?
to the Canadian, to Canadian government?
The W, sorry.
We just described our clinical data of the vaccine, and we got their suggestions so that we can prepare for the applications.
Mais à ce moment-là, est-ce qu'il y a des gens...
But at that point in time, was there anyone within the government of Canada who told you, look, let's be careful, there's a tobacco producer here and that will never be recognized by the World Health Organization. You won't be recognized. Did the government alert you to this?
My personal knowledge, I don't have the answer to the question.
Est-ce que... Excusez-moi, vous dites que vous ne pouvez pas, vous ne voulez pas répondre?
I'm sorry, you're telling us that you can't answer, you don't wish to answer?
I don't know the answer to the question, whether there was anybody from the Canadian government or whether we specify that to the
Maître
government.
Marquis, avez-vous quelque chose à préciser là-dessus?
And Ms. Marquis, do you have anything to add? Was there anyone within your company who pointed out this issue to the federal government? This was not discussed within the framework. I think that I will attempt to clarify matters to the committee. The World Health Organization does not have control over the exportation of products outside of Canada. The World Health Organization was promoting and managing vaccines for the gift of vaccines in surplus in certain countries, but the World Health Organization wouldn't recognize it. And when in March 2022 it said that no, it wouldn't accept it for emergency use listing, were you surprised, or did you just realize that you had forgotten to signal that there was going to be a problem? The World Health Organization might have made a different decision. They made the decision they did in view of the other options that were then available to them. So you gambled that the World Health Organization would say, yes, fine, we'll accept it. During our discussion with the World Health Organization, this issue was not brought up by them at the time. That's $173 million public funds spent by the Government of Canada to invest in your company. Could you make public the contracts that were signed? And please understand, Mr. Tada.
Formula de vaccination. We don't want to know that. But when we talk about taxpayer money, we need clarity and we need transparency. Est-ce que vous êtes prêt à déposer les contrats?
So are you ready to provide us with the contracts linking you to the Government of Canada without going into scientific information, of course, but regarding the amount of money that was paid for by Canadian taxpayers in this agreement?
Clarify that we acted in good faith to satisfy all the contracts we made in government. Second, for advance purchase agreement with PSPC, we already agreed that access on unredacted copy of the agreement can be granted to Committee on Public Accounts so that they can review the agreement for the country.
Thank you, Mr. Tada. Have you finished your answer? Okay, thank you. Merci, Monsieur Deltel.
Thank you, Mr. Deltel. And we will now hear Ms. Vignola for 2.5 minutes. I think it's the Liberals, rather. Oh, yes, I'm sorry, Mr. Perry.
Sorry, Sean.
Dr. Pawlowski for 5 minutes.
A lot has been made of the fact that WHO didn't approve the vaccine, and I think that was a part attributed to the Framework Convention on Tobacco Control. But I have some familiarity with the Framework Convention on Tobacco Control. I was actually part of one intergovernmental negotiating body meeting when they were forming that treaty. I'm pretty sure the answer to this question, but is there anything specifically in the treaty which would prevent WHO approving a vaccine that was made by a company that was involved in the tobacco industry? Ms. Marquis.
So the treaty does refer to the fact that investments that can further the interests of the tobacco industry could be considered by the WHO.
The pivotal word would be could be?
Could be.
So it certainly doesn't bind WHO.
I wouldn't say binding as the word, but it's something that they can consider in their analysis. Because the treaty does contain exceptions for pandemic purposes, so it contains a certain level of interpretation for the WHO.
Or it contains a certain level of interpretation.
Yes.
So in your opinion, had there been no other vaccines out there available for COVID, do you think WHO would still have not approved its use?
Yes, I think so, because it would have outweighed the benefits would have outweighed their considerations for the tobacco industry.
But am I right that at the time that it actually came before them, there were lots of other vaccines, and so in that context, the fact that it was produced with the tobacco company's input became far more relevant than if there were no other vaccines and this wasn't already being addressed.
Correct.
I did not know that relative to the tobacco was used to produce the vaccine, which I find is very interesting. The fact that Philip Morris invested in this company perhaps could be seen as the fact that there are a lot of tobacco producers around the world, for example, in Zimbabwe, and people with pretty limited income. And so, yes, although we would like to see nobody smoking cigarettes anymore, and I'm looking around the room, I'm not sure if anyone here smokes cigarettes. I know there's some of them. However, potentially finding more useful alternatives to the use of tobacco plants could be seen as being socially desirable in a lot of poor countries where you have tobacco producers who have very limited incomes. Am I right? Or perhaps as a company CEO, this isn't one of the things you consider, but I'm suggesting that there might be some social utility, in fact, in using tobacco plants for other purposes other than smoking cigarettes.
Thank you for the interesting question. We are pharmaceutical companies using plants, but we are not selling a plant itself. So we don't have any expertise or knowledge to expand your potentially very nice idea for that. But I think I will leave other expertise to comment on that.
Any more time?
A little over a minute.
So the new company that's being formed out of the remains of Medicago, Aramis, it's made up of former employees, and what, if any, transfer of your factory and your equipment has gone over to them, and was it sold to them, or what's the relationship between Medicago and the new company?
As you understand correctly, Aramis' leadership consists of our former employees, and it is based in Quebec City. We worked with Aramis for the asset transfer as a part of settlement to terminate our SIF agreement with ICED. So we transferred our R&D manufacturing pilot plant in Quebec, equipment, and intellectual property assets to Aramis at the request of ICED, and that was a part of the settlement to terminate that agreement.
So this was kind of a three-way agreement between the Government of Canada, Aramis, and Medicago to kind of in closing down Medicago?
So we worked the transfer to Aramis at the request of ICED, yes.
Thank you, Dr. Pawlowski. Suite et enfin, Madame Vignola.
And now the last round, Ms. Vignola, 2.5 minutes. Thank you, Chair. A little earlier, Mr. Tada, you stated that the technology in the North Carolina factory is not included in the agreements here in Canada. So what happens to that technology? Who does that technology belong to now, and who controls that technology in North Carolina?
In North Carolina are relatively bigger commercial plants. It's not a core of the research and development and IPs. All IPs are basically controlled by our operations in Quebec. Therefore, we transfer our key R&D assets of pilot plant in Quebec, intellectual property assets and equipment to Aramis, but the plants in the North Carolina states which we are using for commercial production is not a part of the transaction.
Very well. So what's happening to those plants?
They are leased plants, so we are negotiating with the landlord to terminate the lease.
Est-ce qu'elles utilisent la même technologie?
Do they use the same technology as the one used in Quebec City?
It is a plant-based VLP vaccine manufacturing facility. So it's the same product, same technology.
Donc, quelqu'un d'autre.
So then someone else could use this technology rather than Aramis using it.
No, really, because this is plant-based VLP. Even though we showed IP, it's not easy. I mean, they need established know-how to produce it. Even if you are given equipment or a building, no one can produce the product we produce based on our IP and technologies. And our IPs, we have protected so far, have been transferred to Aramis, so they own that IP.
Merci.
Merci, Madame Vignola.
Thank you, and thank you, Ms. Vignola.
Mr. Johns, please, for 2.5 minutes.
Who's financing Aramis?
We have no idea.
No. You had stated, you stated that you didn't tell the government about your Philip Morris partnership because it would make your product ineligible at the World Health Organization. Is that true?
No, I don't know. I have no idea whether we did or did not tell PMI's existence to the Canadian government, but what I know is it was a public information that PMI owns minority share of the medical.
But it would have been a deal breaker, likely,
Absolutely.
right? It could have been a deal breaker, right? And that's a concern. Like, did you intentionally fail to warn the government about the likely effects of their involvement, your company's involvement with PMI, and do you think that sort of omission is okay, or should disclosures like that be mandatory?
I have no knowledge. I don't know whether we communicated or we didn't communicate.
But do you think it should be?
I don't know. I don't comment.
I think so. So the Government of Canada tabled the Public Accounts of Canada 2023 on October 24th, 2023. The public account, which disclosed a loss by the Public Health Agency of Canada of $150 million due to an unfulfilled contract by a vendor. According to the document, none of these funds were expected to be recovered. Despite inquiries from parliamentarians and the media, the government initially refused to provide any details of this loss, stating that this information could not be divulged because of confidentiality agreements with the contractor. Can you confirm if Medicago asked the Government of Canada to withhold information with respect to this $150 million loss from Parliament?
No, we haven't. We understand government and Medicago had confidential obligations, but we discussed we can't disclose the detail without prior consent by the other party. So we discussed with the PSPC to what extent they could or we could disclose. So we have never requested to hold that information. And one more thing, $150 million non-advance payment was paid, and we used it at risk manufacturing. And we could not deliver the doses, but WHO rejection of PMI's existence has nothing to do with those situations.
Thank you, Mr. Tata. And next, Dr. Ellis, please, for 5 minutes.
Thank you very much, Sharon and Mr. Tata. Good to see you again. We met at the Public Accounts Committee. Sir, at that time on the 23rd of March 2023, when I questioned you, you agreed that Medicago had received $773 million from the Government of Canada, and that you own the IP and the business assets in Canada. Is that true, sir?
Yes, sir. As of 2020, we made a safe agreement with ICED. Yes.
$773 million, sir.
$173 million was the amount contracted then.
Sorry, sir. At that time, at that committee, you said $773 million. And that number, of course, came from the fact of the number of doses that the Government of Canada agreed to buy. Is that number not correct, sir?
No, it's not correct. I'm not aware of that.
Okay, I would encourage you to go back and read those transcripts, and certainly that's that is in the transcripts from the 23rd of March 2023. Oddly enough, sir, are we here to believe that Mitsubishi, which of course the parent company is an incredibly successful multinational corporation, that out of the goodness of your heart you gave up $40 million IP and business assets in Canada?
We discussed, and our shareholders also in the discussion with an ISED intensively, and we agreed after a good faith negotiation that we will repay the amount owed to the Canadian government, which included $40 million cash and our transferable key R&D assets, including intellectual property.
I guess if I owned Mitsubishi, I would say, why did you do that? They already gave you $150 million. Why would you give IP assets and $40 million? Did they have something over your head?
Contribution from the ISED was for COVID-19 vaccine development and establishment of the manufacturing facility. We developed COVID-19 vaccines and get it approved by Health Canada. And we spent your contribution from the government for that developmental work. But in order to settle the agreement, given where we are, we agreed that settlement includes repayment of $40 million and transfer of the assets.
Sorry, sir, through you, Chair, could you be a little bit more transparent about settling the contract? That doesn't make any sense to me.
I'm not able to disclose further details of the settlement.
But if the Government of Canada agreed as an advance purchase agreement to give you $150 million, you, sir, have made it clear that I think that you've held up your part of the bargain. So why would you give them back $40 million, assets, and IP? That makes no sense.
We have to be very clear that you are talking about $150 million that is an advance payment under APA with PSPC. The other contract is CIF agreement with an ISED. So two agreements are different stuff, sir.
Yeah, I guess that's still going to leave Canadian taxpayers in the dark as to what actually happened. Sir, are there any other people who could testify here, who could shed more light on this?
I want to clear that we have two agreements with the Canadian government. We acted in good faith to fulfill both of the agreements where possible. If we cannot, we followed termination clause of the agreement, or we discussed in good faith, and for CIF agreement, we agreed with, as I said, to terminate or settle the agreement by repaying cash and transfer of the assets.
Yeah, I guess, sir, through you, Chair, if I might, it still leaves the Canadian taxpayer confused as to how all this happened. I mean, I'm sitting here, I've been following and participating in this story for the entire time, and I'm confused. And I think that all of our jobs sitting around this table is to come to a better idea of what happened to the Canadian taxpayers' money. And I guess I don't feel like that's forthcoming, and that's a shame. That being said, sir, I hate to do this to the committee, but I do have to table a motion, and that motion, Chair, will say, given that the Liberal government's carbon tax has had a detrimental impact on the health and livelihood of Canadians, driving 2 million of them to use food banks in March of 2023 alone, the Chair report to the House that the committee call on the government to immediately cancel the carbon tax. Thank you, Chair.
Thank you, Mr. Tata. We'll take the motion as a notice of motion because it doesn't touch on the matter that we are now considering. Thank you for that. We're now at the top of the hour, so a motion to adjourn would be in order. Is it the will of the? Oh, Ms. Sidhu, do you have something that you want to raise? You want to speak on the motion in case it was in order, is that right? Okay.
Yes, Mr. Chair. I'm virtual today. Would it be possible briefly suspend and relate the motion in writing?
I don't think a suspension would be necessary. The motion has been taken as notice, and it isn't in order to be debated today. All right. Mr. Tata, Ms. Marquis, I want to say thank you so much for being with us. greatly appreciate you accepting our invitation and coming to take our questions. Thank you, and all the best for the holidays. Is it the will of the committee to? Oh, there will be no meeting on Wednesday. This is it until Christmas. I know you find that hard. The deadline to, yeah, that's appropriate. Thank you. The deadline to submit a complete witness list for the opioid study is this Friday at 4 p.m. So there have been partial lists submitted, but please complete your lists by this Friday. Is it the will of the committee to adjourn the meeting? We're adjourned.